Hi, everyone. Thank you for having me here today. My name is Dr. Kristin Lo Sicco. I'm an associate professor of dermatology at the Ronald O. Perlman Department of Dermatology at NYU Langone Health and the clinical director of the NYU Skin and Cancer Unit. So why do we call primary scarring or cicatricial alopecias trichologic emergencies? So let's break down the word first. Tricho for hair. And of course, trichologic emergency means that we better treat this right away. Why is that the case? First termed by my mentor, Dr. Jerry Shapiro at NYU. He really coined this term so that we can look at these primary cicatricial or scarring alopecias in a different way, right? Don't wait to treat them because they can result in irreversible damage. And so this is something that we look at very seriously in dermatology, and especially as hair and scalp disorders experts. When patients come to us, we really hope that they're early in their disease course so that we can start them on an oftentimes multimodal approach to therapy to give them the best chance of salvaging hair follicles before they're potentially permanently scarred. We can't get that hair back. Let's talk a little bit about the disease burden with Lichen Planopilaris. So we're going to call it LPP for short. And LPP creates a significant disease burden for our patients, not just from a symptomatology standpoint. These patients might have itch, pain, or burning, or a dysesthesia on the scalp. But they also have evidence of trichologic inflammation as well. How can we tell that? By looking at the scalp to seeing if there's redness or erythema and the degree of scaling or around the hair follicle. And we call that perifollicular erythema and scale. And not only can they have a disease burden from the symptoms that they're feeling, but of course, the hair loss that comes subsequent to longstanding inflammation that can then turn into fibrosis results in a loss of their sense of self. It's more than just something that is considered cosmetic. I think that the one unfortunate thing amongst US-based insurance companies right now is that anything with the word hair or alopecia somehow gets categorized as cosmetic. And we're really trying to change that landscape. Not only do we know that diseases like Lichen planopilaris can have other systemic conditions that are associated with it. For example, autoimmune thyroiditis is one of the more common. It's a disease that's worthy of treatment, right? This is not just something that's cosmetic. It causes a significant disease burden and a very negative impact on someone's quality of life. And so one could say the same about atopic dermatitis, for example, right? That causes a visible abnormality that people see, and it can cause significant symptoms like pruritus, as well as a negative impact on quality of disease, right? So there really should be a comparison that hair and scalp disorders should be considered the same and worthy of treatment. And I say that because our hope is that we can in the next few years have the first FDA-approved medication ever for any primary scarring alopecia, let alone lichen planopilaris. But I really want to urge our community to encourage advocacy for our patients and from the insurance company standpoint to catch up to us and approve these medications right away once hopefully we can get the first FDA-approved medication on the market. So let me explain. We've already proven that despite multiple JAK inhibitors, at least when the first two came out for the treatment of severe alopecia areata, and we've published both of these studies from our team at NYU, that patients still had a degree of um, administrative burden, right? So we had medications that were still denied, multiple levels of appeal, and there were, for some patients, a significant delay between us putting the prescription in and the patients taking that medication. We've already proven for multiple non-scarring types of alopecia, including androgenetic alopecia and alopecia areata, that time is of the essence. What does that mean? That means that if you delay treatment, it's possible that when you start at the same level of severity, let's say you and the person sitting next to you both have severe inflammation on your scalp, if one starts medication very soon versus the other one is delayed, there's a possibility that you might not get the same great response to the same medication. Of course, we're looking into this data now, but it's already been proven for multiple types of non-scarring alopecia. And that's from a research and advocacy standpoint. We really want to encourage insurance companies and the community to look at this as something beyond just a visible or cosmetic issue. It is a real medical issue that is worthy of treatment, and treatment is of the essence, right? A trichologic emergency for something that can have a significant disease burden and negative quality of life for patients. We want our patients not only have medications they can choose from, but access to care as well is equally important. Currently, there are no FDA-approved medications for any primary scarring or cicatricial alopecia, including lichen planopilaris or LPP. So what does this create? This creates, not only confusion amongst the community. What treatment algorithm should I be following? Should I be taking a multimodal approach? And that means, should I be doing injections in addition to topical medications, in addition to oral or systemic therapy with somebody for more severe disease? And not only can that lead to confusion, right, because there aren't any FDA-approved medications, but also lack of coverage for medications that we know demonstrate efficacy. So I'll give you an example. Dr. Marianne Senna out of Leahy Clinic ran a study with delgocitinib. So with delgocitinib as a topical JAK inhibitor, as we know, because we know that the genase kinase pathway and other cytokines that are related are involved in the pathogenesis of lichen planopilaris. She ran that study and showed that patients with primary scarring alopecia, specifically frontal fibrosing alopecia, did very well on monotherapy. And that means using this therapy without anything else. And we know that frontal fibrosing alopecia and lichen planopilaris are related conditions. And so, for example, if I have someone come to clinic saying, "Hey, I saw this study, I would love to explore this medication," it's very unlikely that we're going to get that medication covered unless they also have concomitant atopic dermatitis or hand eczema, because it's not FDA approved for any hair and scalp disorder, including lichen planopilaris or frontal fibrosing alopecia. And so just because we have clinical trials, if we don't have the FDA approval, our patients can still face difficulties having access to care. And so I think having the first FDA approved medication ever would be a huge win, would be a game changer for people with moderate to severe disease, so that hopefully we can have a medication that's not only efficacious and safe, but accessible to the public as well. Brepocinib, as we know, is a JAK inhibitor. And this medication is in phase 2, phase 3 trials for lichen planopilaris. How are we measuring success for patients? So first, patients with moderate to severe disease are included. Those that have lower disease severity are excluded from the study, because this is really a focus on moderate to severe disease. How does one define that? So I alluded to this earlier in our conversation, that the degree of redness or erythema and scaling around the hair follicle can help us to denote more active disease. So the more erythema and the thicker the scaling around each of these hair follicles can denote a higher amount of inflammatory infiltrate. And so one that has moderate to severe disease, according to the IGA, or the Investigator Global Assessment, are included. And patients also who have a disease burden from a symptomatology standpoint, right? So itching, pain, burning, or dysesthesia as well. So these patients have symptoms on their scalp, and they also have trichologic evidence. And that means when we look with our handheld microscope or dermatoscope, we can see a degree of erythema or scaling around the hair follicle and a more moderate to severe level to be included in this study. And then hopefully by the end of this study, over a 6-month period, and there is an extension as well, they will have either quiescent disease or near quiescent disease, so an IGA score of 0 or 1. And of course, improvement in their symptoms as well. So one might ask why, LPPAI which an indices that has been validated, is being used in this trial as a secondary endpoint. But the reason why the IGA, which by the way is a novel IGA that was developed by hair experts as well and was validated, is being used for this trial as the primary endpoint is because the LPPAI index is not an indices that's accepted for studies that will be applying for an FDA approval. So that's why a novel IGA was actually created for this study that was validated prior to use in the study. But the LPPAI is a secondary outcome as well. The beautiful thing about dermatology is that we can find multiple inflammatory cascades that can overlap in disease processes, and the JAK-STAT pathway is one of those that has been discovered to be part of the pathogenesis of lichen planopilaris. We already know this from the delgocitinib study, as a topical JAK inhibitor that can be helpful for frontal fibrosing alopecia, the sister diagnosis to lichen planopilaris. And so our hope is that that patients will benefit greatly with moderate to severe disease, having a JAK inhibitor that's a pill or a systemic form, right, to treat them from the inside out. And so, yeah, very grateful that, we can have overlapping mechanisms where one medication can be used for multiple disease processes that we treat, like sarcoidosis, like dermatomyositis, and now hopefully lichen planopilaris. My hope is that this medication, brepocinib specifically, will be the first systemic or oral medication approved for moderate to severe lichen planopilaris specifically. And like we talked about earlier in our conversation, I'm really hoping that the FDA approval will help to break down some barriers regarding timely insurance approval. So that means a short period of time between me or any dermatologist putting in the prescription, and the patient actually getting the medication in their hands, right? Because like we said, time is of the essence. One thing, and we did a study on this when the JAK inhibitors came out for alopecia areata, regarding dermatologists' comfort of using JAK inhibitors. And not surprisingly, those that had less knowledge regarding the JAK inhibitors were less likely to prescribe it in their practice, and that makes sense. We know that there are boxed warnings on multiple JAK inhibitors, including the oral JAK inhibitors that we use for alopecia areata, and of course, other conditions that we treat, cutaneous lupus, dermatomyositis, so on and so forth in dermatology. But what I can tell you is that we did a study in JAMA Dermatology a few years ago, collaborating with our cardiologist at NYU, Dr. Michael Garshik, and we did the meta-analysis and putting together really all of the trials that were done using oral JAK inhibitors for dermatologic indications. So that included alopecia areata, atopic dermatitis, vitiligo, psoriasis, so on and so forth. And what we found that there was not a statistically significant increase in those boxed warnings, and that included MACE events, so that's a non-fatal myocardial infarction, venous thromboembolism, or VTE, or death. And so we were very happy to see that. That our patients overall were not at increased risk of those box warnings. Now, what are some caveats to take away from that? Remember, patients in dermatology generally, compared to the rheumatology cohort, for example, which is where the box warnings came from when tofacitinib was used for rheumatoid arthritis. And those patients in the New England Journal study were all on methotrexate, and about half of them were on oral prednisone as well. They were also older individuals compared to the dermatology individuals in the clinical trials, and they had more comorbidities and higher risk factors for cardiovascular risk factors, right, including hypertension, so on and so forth. So patients in dermatology are generally healthier and younger individuals. So it's still important for us to select the most ideal candidate for JAK inhibitors, but what we can tell you is that the emerging data is showing not only efficacy but safety as well. One other caveat that I want us to consider is that when we did the meta-analysis using the randomized controlled trials and using JAK inhibitors in dermatology, these studies were not done over multiple years and years, right? So when we're looking at some of these outcomes like cardiovascular outcomes, we really would love to see studies that are done over multiple years, right? So that because sometimes it takes time for some of the cardiovascular manifestations to occur. And those studies, of course, are ongoing. So really excited to see some of those longer term studies come out. But right now, we can tell you the emerging data is showing not just efficacy, but safety in the dermatologic cohort. But of course, it's really important for the patient to partner with their dermatologist to make informed decisions about what medication is right for them. And one other plug that I wanted to put in for us today is that for dermatologists and patients alike, there's a great resource through the Scarring Alopecia Foundation, or SAF for short. So if you can go to our website, there are great resources available for patients. It is a patient-facing organization, but there are also resources that dermatologists can utilize as well. So consider supporting SAF or the Scarring Alopecia Foundation, and certainly logging onto their website and signing up for their mailing list so that you can benefit from the free resources that they give to the community alike. Thanks for having me today.